Welcome to the Radonc Smart Review GU Cancer Series.
Glad to be here for this one.
So imagine a patient survives a grueling 6-hour radical surgery to remove their bladder.
Right. The surgeon comes out to the waiting room, shakes the family's hands and says, well, we got it all.
Yeah, the margins are clear.
Exactly.
And the patient recovers, they adapt to their new urinary diversion, and they really think they are completely out of the woods.
Absolutely. But then, say, 6 months later, they're sitting in the emergency room with this intractable, agonizing pelvic pain.
Maybe unilateral leg swelling.
Right. Failing kidneys.
It's awful because the cancer is back.
Yeah.
And not in the lungs, not in the liver, but right there in the surgical bed where the bladder used to be.
It's one of the worst scenarios we see.
It really is. So today, we're going to learn how to prevent that exact nightmare and conversely, what to do when a bladder-sparing approach hits a similar wall. This is episode 16, Bladder Post-Cystectomy Radiation, Follow-Up, and Salvage Pathways. We have a very specific mission for this session, pulling from our most recent clinical guidelines and trial data.
Yeah, we're going to permanently fix two major board-relevant mistakes that commonly trip up residents, and frankly, even some practicing attendings.
Oh, for sure.
Because those two traps will instantly derail a board exam, and more importantly, they'll severely compromise patient care if you fall into them in the clinic.
So what's the first one?
The first mistake is defaulting to the outdated dogmatic belief that radiation has absolutely no role after a patient undergoes a radical cystectomy.
Ah, the no radiation after surgery trap. And the second?
The second mistake is hesitating or, recommending the wrong local therapy when a patient returns with an invasive recurrence after a trimodality bladder preservation protocol.
Right. Modern bladder cancer management is just this incredibly dynamic interplay between surgery, radiation, and systemic therapy.
It really is.
And you, sitting in the listener seat, are essentially stepping in as the third physician in the room with us today. You have to know exactly when to pivot from one modality to the other.
Exactly. So to build a clean, reliable framework for you, we're going to ground this entire discussion in real clinical scenarios.
Yeah, let's introduce case A. I want you to visualize this patient. You were consulted on a 65-year-old man. He is 3 months out from a radical sister prostatectomy with an extended bilateral pelvic lymphadenectomy and an ileal conduit diversion.
Okay.
For surgery, his workup showed CT3 high-grade urothelial carcinoma on his initial TURBT.
And for those just tuning into the GU rotation, that's the transurethral resection of bladder tumor.
Right, where the urologist goes in with a scope and scrapes the tumor down to the muscle layer.
Exactly. Now, did he have hydronephrosis?
He had no hydronephrosis, meaning the tumor wasn't blocking the ureters, and his performance status was phenomenal.
Well, with a CT3 tumor and excellent baseline fitness, the standard of care dictates he receives neoadjuvant systemic therapy before anyone touches him with a scalpel.
Right, because the goal there is to eradicate micrometastatic disease early, right?
Yeah, and potentially downstage the primary tumor to make the surgical resection cleaner.
So he received the classic regimen 4 cycles of neoadjuvant dose-dense MVAC.
Methotrexate, vinblastine, doxorubicin, and cisplatin.
Exactly. We call it dose-dense because we squeeze the treatment cycles closer together, usually over 2 weeks instead of 4.
Right, supported by GCSF to keep his white blood cell counts from totally crashing. It's a highly aggressive approach.
It is. But here is the critical pivot, the final surgical pathology. Despite that heavy-hitting neoadjuvant chemotherapy, his final pathology shows IPT3B disease.
Wow. And the Y indicates post-therapy.
Right. He has 2 positive pelvic nodes out of 20 removed, so P and 1. And the pathologist specifically notes the presence of extranodal extension.
That's a huge red flag.
Yeah. The surgical margins themselves are technically negative, though. He has recovered beautifully from the surgery, and the urologic oncology team is asking you a direct question. Is there a role for adjuvant pelvic radiation, and how does that fit in with his planned adjuvant immunotherapy?
Man, this is a quintessential high-yield scenario. Let's look at the underlying biology of that pathology report first.
Okay, let's break it down.
So, IPT3B means the tumor has grown through the bladder muscle and invaded the macroscopic perivesical fat. But more alarmingly,
The extranodal extension.
yes, extranodal extension means the cancer cells inside those 2 positive lymph nodes didn't just stay neatly inside the node.
Right.
They utilized matrix metalloproteinase to literally chew through the lymph node capsule and spill out into the surrounding pelvic connective tissue.
Oh, wow. So when you see extranodal extension, the concept of a negative surgical margin becomes somewhat illusory, doesn't it?
That's exactly it. The surgeon took out the macroscopically visible tissue, but microscopic cancer cells are almost certainly seeded throughout the soft tissues of the pelvic sidewall.
I see.
Therefore, this is a fit patient with very high-risk locoregional disease. Adjuvant nivolumab is guideline-supported here to handle the systemic risk. But postoperative radiation should absolutely be discussed in a multidisciplinary setting as a selective locoregional control strategy.
Okay, let's play devil's advocate here and address the elephant in the room. Because
Yeah.
I know what the skeptical resident is thinking.
Let's hear it.
Wait, didn't we learn in medical school that urothelial carcinoma is basically a systemic disease? I mean, once the bladder is out and the margins are technically negative, it's a medical oncology problem.
Right, the old we got it all mentality.
Yeah, the thought process is like the surgeons removed the primary organ, they scraped out the lymph nodes. If the cancer comes back, it's going to be in the liver or the lungs. Why subject the patient to pelvic radiation?
And that mindset right there is trap number one,
Mm,
and it is dangerously outdated. Yes, the systemic risk is massive, sure, but surgery alone does not fully solve locally advanced bladder cancer in the pelvis. We have a genuine, isolated pelvic recurrence problem in this specific subset of patients.
How high of a risk are we talking?
When a patient has PT3B disease and extranodal extension, the failure rate right there in the surgical bed can exceed 30 to 40% in some historical series.
Wow, 30 to 40%. We need to define what a pelvic recurrence actually looks like for a patient without a bladder because it is an absolute quality of life disaster.
So it really is. This isn't just a rising PSA like in prostate cancer where the patient feels perfectly fine.
Right.
A pelvic recurrence after a cystectomy is one of the most brutal localized failures in oncology. The tumor grows aggressively in the presacral space or the pelvic sidewall.
And that invades the lumbosacral plexus, right?
Exactly, causing severe intractable sciatic pain that often requires heavy narcotics or even nerve blocks just to make the day bearable. It encases the ureters, causing bilateral hydronephrosis and renal failure. It can invade the loops of bowel that have fallen into the empty pelvis.
Creating fistulas.
Yeah, abnormal connections between the bowel and the skin or the bowel and the surgical bed. It can completely compromise the stoma and their ileal conduit. The patient is left unable to pass urine or stool normally.
And the most tragic part is that once a massive pelvic recurrence establishes itself in a post-cystectomy patient, our salvage options are practically non-existent.
Right. The urologist cannot operate on it again.
The anatomy is essentially frozen by tumor and scar tissue, and trying to deliver salvage palliative radiation to a massive tumor in a pelvis filled with adhered loops of small bowel.
It's incredibly toxic.
Yeah, we often can't reach a high enough dose to control the tumor without causing a bowel perforation.
That is precisely why the strategy here must be prevention. We have to treat the microscopic disease before it organizes into a macroscopic tumor mass.
But we must carefully define the who, right? Because we are not talking about radiating every single post-cystectomy patient.
Absolutely not. The selection criteria are everything.
So if a patient had a PT2 tumor, organ-confined disease, negative surgical margins, and no involved lymph nodes.
Postoperative radiation is completely off the table. The local recurrence risk is in the single digits, and the toxicity of radiation would vastly outweigh any theoretical benefit.
You just send them back to urology or medical oncology for routine surveillance.
Right. The patients who earn this conversation, who belong in the radiation oncology clinic for this adjuvant discussion, are the ones with very high locoregional risk.
And how do we define that for the boards?
We define that primarily through three pathology triggers. First, advanced local stage, so PT3B to PT4 disease, where the tumor has heavily invaded the perivesical fat or adjacent structures like the prostate stroma or vaginal wall.
Got it. What's the second?
Second, positive pelvic lymph nodes, particularly with the extranodal extension we saw in case A.
And the third?
Third, positive soft tissue surgical margins.
Right. I would add that a severely limited nodal yield from the surgeon might also raise your antenna.
Oh, good point.
Like, if they only retrieved 3 or 4 lymph nodes during the dissection, the chances of harboring undetected microscopic nodal disease skyrocket.
Very true. But stage, nodes, and margins are the cleanest, most defensible triggers for your board exams. And our case of patient hits almost all of those triggers.
Okay, so we've established the rationale. But as evidence-based oncologists, we can't just rely on theoretical biology.
No, we need the clinical trial data to defend this recommendation in a multidisciplinary tumor board.
Right. So we have four major evidence anchors to walk through. Let's start with the historical foundation, the randomized Egyptian trial.
Okay, so the Egyptian trial is our biological proof of concept, but it comes with a massive, glaring caveat that you must state out loud if you bring it up.
What's the caveat?
This trial randomized post-cystectomy patients to observation versus adjuvant radiation, and it showed a profound improvement in locoregional control for the radiated group. However, the patient population in Egypt at that time had a very high incidence of schistosomiasis.
Let's break down why that matters. Schistosomiasis is a parasitic infection, right?
Yes, the parasite lays eggs in the bladder wall, which causes intense chronic inflammation over decades.
And this chronic irritation forces the normal urothelium to undergo squamous metaplasia, eventually leading to squamous cell carcinoma of the bladder.
Exactly, which is biologically distinct from the transitional cell, or urothelial carcinoma. That makes up about 90% of the cases we see in North America and Europe.
Which are typically driven by smoking or occupational chemical exposures.
Right. And squamous cell carcinoma tends to be more locally aggressive and less prone to early distant metastasis compared to urothelial carcinoma.
I see. So because of that distinct natural history, you can't simply take the massive local control benefit seen in the Egyptian trial and assume it applies perfectly to a modern North American urothelial cohort.
Exactly. What it does prove, however, is that applying ionizing radiation to a postoperative surgical bed can successfully sterilize microscopic disease and prevent local failure.
But we needed a modern North American trial to validate that concept for urothelial carcinoma. Which brings us to our second evidence anchor NRG-U0001.
Right.
My understanding is that this trial attempted to answer the question but hit a massive structural wall. It closed early due to poor accrual. Why did the medical community fail to enroll patients in this trial?
It was a perfect storm of provider bias and structural anxiety.
Yeah.
It is crucial to understand that GO01 did not close because the radiation was proven toxic or ineffective.
Wait, really? It wasn't stopped for harm?
No, the data monitoring committee didn't stop it for harm. It closed because we couldn't convince enough urologists and medical oncologists to refer their patients.
Well, I can completely understand the urologist's perspective.
Oh, absolutely.
I mean, they just spent 6 to 8 hours in the operating room performing a massive extirpative surgery and painstakingly creating a delicate bowel anastomosis for a neobladder or an ileal conduit. The last thing they want is a radiation oncologist firing 50 grays of x-rays at their newly constructed healing bowel diversion.
Exactly. The fear of catastrophic bowel toxicity like strictures, leaks, or fistulas was pervasive.
Yeah.
Furthermore, medical oncologists were highly focused on systemic failure.
Right. They wanted to get patients onto adjuvant chemotherapy or immunotherapy trials and viewed local radiation as a distraction or a delay.
Yeah. So the failure of GO001 highlights that the lack of definitive Phase 3 overall survival data in North America is a structural trial failure, not a scientific failure of the modality itself.
Fortunately, we don't have to rely on a failed trial for our defense. We have the third evidence anchor, which is the hero of modern bladder radiation guidelines, the BART trial.
Yes, the BART trial. This is the modern standard you must quote.
What made the BART trial different, and how did it finally move postoperative bladder radiation from theory into acceptable practice?
The BART trial succeeded because it leaned heavily into modern radiation physics and imaging technology. It was a randomized Phase 2 trial specifically targeting selected high-risk patients after cystectomy. Instead of using old, rudimentary 3D conformal radiation techniques that essentially bathe the entire pelvis, including all the small bowel and high-dose radiation, BART mandated the use of image-guided IMRT.
Intensity modulated radiation therapy. IMRT is the game changer here.
It's a huge game changer.
For those visualizing this, older techniques used 4 static beams that intersected in the pelvis, creating a block of radiation that caught everything inside.
Right, just a big box.
But IMRT, and specifically VMAT or volumetric modulated arc therapy, uses a linear accelerator that rotates around the patient while the multi-leaf collimators, these heavy tungsten leaves inside the head of the machine, constantly slide back and forth.
Which allows us to literally sculpt the radiation dose.
Yeah, painting the high dose over the target areas while carving out steep dose gradients to protect the adjacent normal bowel and the urinary diversion.
Exactly. And the prescribed dose in the BART trial was 50.4 GUI, delivered in 28 daily fractions. This was targeted specifically to the cystectomy bed and the high-risk pelvic lymph node basins.
And by using this highly conformal approach, the BART trial was able to demonstrate a significant improvement in pelvic disease control.
Yes, it was.
What about the toxicity? Because that was the big fear that killed GU001.
The toxicity was manageable. The trial proved that with modern IMRT and daily image guidance, you can deliver this dose to a postoperative pelvis with acceptable rates of severe, grade 3 or higher gastrointestinal and genitourinary toxicity.
But let's be very disciplined about the takeaway here. The BART trial showed improved locoregional control. It did not show a definitive overall survival benefit. We have to be honest about the data we have.
Honesty is the hallmark of a mature oncologist, which brings us to the fourth evidence anchor, which is the ultimate synthesized conclusion you should present.
And what's that?
Postoperative radiation in this setting is fundamentally a locoregional control strategy.
Right.
You are not claiming that pelvic radiation will cure a stray metastatic cell that is already lodged in the liver. You are stating that it prevents the specific, devastating quality of life disaster of a massive pelvic recurrence.
That framing sets up the conversation beautifully when we bring it back to our case of Barreau, a patient and his adjuvant immunotherapy.
Yes, the nivolumab.
Yeah, the urologist wants to know how radiation fits with adjuvant nivolumab. And nivolumab, as a PD-1 inhibitor, works by blocking the immune checkpoint pathway, essentially taking the brakes off the patient's own T cells so they can hunt down micrometastatic disease.
Right, based on the Checkmate 274 data, this is the standard of care for high-risk muscle-invasive urothelial carcinoma after surgery.
So do we give the radiation instead of the immunotherapy?
We absolutely do not view them as mutually exclusive. They are tackling two distinct biological problems.
Okay, how so?
The nivolumab is patrolling the systemic circulation, addressing the distant metastatic risk. The radiation is addressing the macroscopic or dense microscopic tumor deposits left behind in the fibrotic, hypoxic surgical bed.
Because the immune system often struggles to penetrate those dense immunosuppressive microenvironments in the pelvis, right?
Exactly. The radiation physically destroys the DNA of those clustered cancer cells, potentially releasing tumor antigens that could even synergize with the immunotherapy.
Oh, like an abscopal effect.
Potentially, though we're still studying that abscopal effect in this specific setting.
So they are complementary. But practically, how do we sequence them? Are we delivering them concurrently?
The safest, most accurate approach is that sequencing is highly individualized and must be hammered out in a multidisciplinary tumor board.
Gotcha.
We do not currently have a definitive, large-scale randomized trial dictating the exact sequencing of pelvic IMRT and nivolumab in this specific postoperative setting.
So it's usually sequential.
Often, yes. Often they are approached sequentially to avoid overlapping toxicities. A common paradigm might involve starting the systemic therapy to address the immediate distant risk and then integrating the radiation once wound healing is fully assured, or vice versa, depending on whether the local or distant risk is deemed more imminent.
Makes sense. Let's get into the technical weeds of the radiation planning, because deciding to treat case A is only half the battle.
Executing it safely is where the radiation oncologist earns their keep.
Absolutely. So what exactly are we contouring? Let's talk about the history first, because the old framework explains a trap that residents still fall into.
You are referring to the old Bauman consensus.
Right.
That approach was heavily margin-based. It essentially operated on a quadrant system,
Like if the surgical margin was positive anteriorly, you treat anteriorly?
Exactly. If the margin was positive near the rectum, you targeted that posterior area. It was an attempt to be extremely minimalist to spare the bowel.
But contemporary failure analyses completely dismantled that approach, didn't they?
Oh, absolutely. When researchers mapped out where patients were actually failing after cystectomy, they found the microscopic disease wasn't neatly confined to a specific margin quadrant.
Where was it?
It was scattered diffusely throughout the soft tissues of the entire surgical bed, particularly deep down where the bladder was resected from the prostate capsule, the seminal vesicles, or the vaginal cuff.
Which means the Bauman consensus is outdated.
Right. The modern default for these selected high-risk patients requires broader, more comprehensive coverage. The target is the cystectomy bed plus the local pelvic nodes.
And which nodes specifically?
We must cover the internal iliac, external iliac, obturator, presacral and distal common iliac nodal basins.
The presacral nodes are specifically crucial to remember, right?
Very crucial.
Because the lymphatic drainage of the posterior bladder wall and the prostate tracks directly back into the presacral space. If you omit that basin, you are leaving a major escape route wide open.
Exactly.
Think of the pelvis like a high-stress mechanical joint in a complex machine. Post-op radiation in this setting isn't about dipping the entire machine into a vat of rust-proof paint. It's a highly targeted, calculated spot weld on the specific anatomical brackets, the surgical bed, and those local nodal chains where the microscopic disease is under the most pressure and is most likely to break through the tissue planes again.
I like the spot weld analogy. But to execute that weld safely, your simulation and daily setup have to be flawless.
What's the setup like?
Well, this patient has heavily altered anatomy. When they come in for their planning CT scan, you must physically mark the stoma on their skin with a radio-opaque wire.
Oh, so you can see it on the scan.
Right. You need to be able to see exactly where that stoma sits on the CT slices. You also have to meticulously delineate the entire length of the ileal conduit in your contouring software.
And when the patient is on the treatment table, you absolutely must use daily image guidance.
Mandatory. We are talking about daily cone beam CT scans before every single fraction. You cannot rely on simple 2D kilovoltage films aligning to the bony pelvis.
No, you need to see the soft tissue, the filling of the rectum, and the position of the small bowel every single day because it shifts constantly.
Exactly. And the dose, as we adopted from the BART trial, is typically 45 to 50.4 GY, usually recognized as the 50.4 GY in 28 fractions regimen.
Okay.
But here's the massive warning I have for anyone drawing these target volumes. Do not let your fear of bowel toxicity cause a geographic miss.
The bowel avoidance instinct is incredibly strong, though, right? I mean, you are scrolling through the CT scan, you see a massive loop of small bowel dipping deep into the pelvis right next to your target volume.
And the temptation is to just carve a giant hole in your clinical target volume to keep the dose off the bowel.
Right.
If you carve a hole in your oncologic target, you're going to see a recurrence in the exact spot you underdosed. The cancer does not care that you were trying to spare the ball.
Well, what's the right approach?
You have to define the oncologic target, first ensuring robust coverage of the distal common iliac and presacral nodes, and then use the power of the VMAT optimization algorithm to sculpt the dose around the normal tissues as best as physically possible.
This highlights the unavoidable functional trade-off. We have to explicitly name this trade-off for the patient during the consultation.
We do.
Because the native bladder is gone, we aren't worried about radiation cystitis, bleeding from the bladder wall, or urinary frequency anymore. What is the priority now?
The functional trade-off is locoregional control versus bowel and diversion-related morbidity. That is the fulcrum of this entire treatment decision.
Right.
Once the bladder and prostate or uterus are removed, the pelvic floor is empty. Fixed loops of small bowel drop deep into that empty space. When we irradiate that bowel, we cause mucosal damage and inflammation.
And in the acute setting, during the 5 weeks of treatment, this means loose stools, intense urgency, cramping, and potential irritation or skin breakdown around the stoma.
Yes, but the late toxicity, the damage that shows up months or years later, is what requires careful counseling.
Because the radiation causes subtle fibrosis and vascular changes in the bowel wall, right?
Exactly. A process called endarteritis obliterans, where the small blood vessels narrow and scar. This can lead to chronic diarrhea, malabsorption, or intermittent bowel obstructions.
And the ileal conduit itself is made of bowel tissue, too.
Right. Irradiating it can cause dysfunction, strictures at the ureteral anastomosis, or in rare catastrophic cases, fistula formation. You are radiating a heavily altered, fragile surgical landscape.
Which is why the counseling sentence you should use with the patient goes something like this. Your pathology report shows aggressive features that carry a significant localized risk of the cancer returning right here in the pelvis. We have modern trial evidence showing that targeted postoperative radiation can lower that failure risk. The trade-off is added toxicity to your bowel and your urinary diversion.
That's perfect.
And then you add, I want to frame this as a pelvic control decision to prevent future pain and obstruction, not a guarantee of longer overall survival. Because your local risk is so high, this needs to be a core part of our management discussion.
It is honest about the benefit and unflinchingly honest about the trade-off. No overselling.
Absolutely. While we have thoroughly dismantled trap number 1, we understand when and how to use radiation after a bladder is removed.
Let's pivot and tackle trap number 2, which deals with the opposite scenario.
Right. What happens when a patient fights to keep their bladder and the cancer finds a way back anyway? Let's introduce case B.
Let's hear it.
We have a 72-year-old woman. She is 18 months post-trimodality therapy. To level set, trimodality therapy for bladder preservation involves a three-pronged approach. A maximal TURBT by the urologist to remove as much visible tumor as possible, followed immediately by definitive radiation therapy with concurrent radiosensitizing chemotherapy.
Okay. For her initial presentation, she had a 3-centimeter CT2N0 tumor, muscle invasive but localized.
Right.
She underwent the maximal resection and then received a definitive radiation dose of 55 GY in 20 fractions with concurrent 5-FU and mitomycin C. This is a very standard, highly effective, hypofractionated bladder preservation regimen.
Let's briefly touch on the mechanism of that chemotherapy, because we aren't giving 5-FU and mitomycin C here to kill microscopic disease in the lungs.
No, we are giving it to make the radiation work better.
Right. 5-FU is a thymidylate synthase inhibitor, so it disrupts DNA synthesis.
And mitomycin C is a cytotoxic antibiotic that cross-links DNA, and it is particularly effective in the hypoxic, oxygen-starved center of a tumor.
So when you combine those DNA-damaging agents with the DNA strand breaks caused by the radiation, the synergy is just lethal to the bladder tumor.
Extremely effective.
And she had a fantastic initial outcome. She achieved a complete clinical response, no visible tumor on follow-up scopes, negative biopsies, and she has been on routine surveillance.
Okay,
But at her 18-month follow-up cystoscopy, the urologist visualizes a new solid lesion on the right lateral wall. They biopsy it. The pathology comes back as invasive high-grade urothelial carcinoma. The tumor has invaded the muscularis propria again.
It is a true muscle-invasive recurrence.
Yeah. We immediately restage her. CT scans of the chest, abdomen, and pelvis are clear. There is no lymph node involvement and no distant metastatic disease.
Well, her performance status is excellent, I assume.
Her performance status is excellent, and her renal function is perfectly normal. She is fit for major surgery.
Okay. So she looks at you and asks the critical question, what now?
Before we deliver the definitive answer, we need to acknowledge how we even found this recurrence. Catching a recurrence at 18 months perfectly localized to the bladder without distant spread is not luck.
No, it is the result of rigid, uncompromising surveillance. Surveillance is the absolute backbone of any bladder preservation program. If you are going to leave the organ in the body, you have to watch it like a hawk.
What is the standard schedule?
The schedule requires immense discipline from both the patient and the physician. The clean framework to memorize is this. The patient undergoes a rigid cystoscopy with the urologist every 3 months for the first 2 years.
Okay, Q 3 months.
That frequency drops slightly to every 6 months for years 3 through 5, and then annually for the rest of their life.
And in urine cytology evaluation, looking for shed cancer cells in the urine travels with every single one of those scopes, right?
Every single one. And we cannot rely on the cystoscope alone because the scope only sees the inside of the bladder.
Right. What about the imaging?
Cross-sectional imaging is mandatory. We require a CT or MRI of the chest, abdomen, and pelvis every 6 to 12 months for the first 3 to 5 years to monitor the pelvic lymph nodes and distant organs.
This brings up trap number 3 for the boards. When you order that cross-sectional imaging, what anatomical structures must you specifically ensure are visualized with delayed contrast phases?
The upper tracts. You must visualize the renal pelvis and the entire length of the ureters.
Because urothelial carcinoma is uniquely a field disease, right?
Exactly. The entire urothelium, from the calyces in the kidneys down through the ureters, the bladder, and the urethra, has been exposed to the exact same carcinogens, whether from tobacco smoke or chemical exposures, for decades. It carries the same genetic field defects.
So if you only stare at the bladder with a cystoscope and you don't image the upper tracts with CT urography or retrograde pyelograms, you are flying completely blind.
Right. A new tumor could easily be growing silently in the kidney while you are celebrating a clear bladder. It is a whole urothelium survivorship problem.
Okay, so we followed the rules. We executed the Q3-month cystoscopy, we monitored the upper tracts, and we caught this muscle-invasive recurrence at 18 months. Now we need to answer her question. What now?
Which brings us to the 3-bucket rule. This is the cleanest mental model for managing post-trimodality recurrences.
The 3-bucket rule makes an incredibly complex emotional and clinical situation pretty straightforward. When a patient recurs after bladder preservation, you sort their pathology into one of 3 buckets.
Exactly. Bucket 1 is the superficial or non-muscle invasive recurrence. We are talking about TAT tumors, T1 tumors, or carcinoma in situ.
If a patient falls into bucket 1, the disease hasn't invaded the muscle again. How do we handle them?
In carefully selected patients, specifically those whose bladders still function well, who have adequate capacity, and where the recurrence is small and easily resectable, conservative management is perfectly reasonable.
Like what?
The urologist can perform another TURBT to scrape the superficial tumor out. Furthermore, you can utilize intravesical therapies like BCG, which is an attenuated strain of tuberculosis bacteria instilled directly into the bladder to provoke a massive local immune response.
And the key pearl here is that prior radiation does not contraindicate the use of BCG for superficial recurrences.
Correct, but then we have bucket 2.
Which is the muscle invasive recurrence. This is our case B patient. The tumor has invaded the muscularis propria. What is the definitive answer?
The definitive answer for bucket 2 is salvage radical cystectomy, complete with an extended pelvic lymphadenectomy and the creation of a urinary diversion.
And just to close out the model, what is bucket 3?
Bucket 3 is nodal or distant recurrence. If the disease has escaped the bladder and established itself in the pelvic lymph nodes, the liver, or the lungs, that patient moves immediately into a systemic therapy conversation first.
Right.
Local radiation or surgery might be used selectively down the line for palliation or metastasis-directed therapy in oligometastatic scenarios. But systemic agents, chemotherapy, immunotherapy, or antibody-drug conjugates drive the bus.
Okay, let's focus intently on bucket 2 and solve case B, because this is where trap number 2 lies. The patient is sitting across from you. She is terrified of losing her bladder. I mean, that's why she chose trimodality therapy in the first place.
Of course.
I'm going to play devil's advocate. She had a phenomenal response the first time. The disease is completely localized to the bladder wall. Why can't we just give her more radiation? Maybe stereotactic body radiation, SBRT, targeted just to the tumor? Or why can't we just try aggressive intravesical BCG since it hasn't spread to the lymph nodes? She wants to keep her native organ.
You have to emphatically shut that line of thinking down. That is trap number 2, and it will harm the patient. Do not offer more local bladder-sparing therapy for a muscle-invasive recurrence after full-dose chemoradiation.
But why?
Let's look at the physics and biology of the irradiated tissue. This patient has already received 55 Bg to the entire bladder. The smooth muscle, the vasculature, and the connective tissue of that bladder have been taken to the absolute brink of their radiation tolerance.
Right, the late effects of radiation involve chronic ischemia and fibrosis.
Exactly. If you attempt to deliver another curative dose of external beam radiation to that previously irradiated target, the tissue will simply break down. You will cause catastrophic radiation necrosis.
The bladder will just contract into a small, fibrotic, non-functional ball.
Worse, you risk creating horrific fistulas into the rectum or vagina, and the patient will experience severe, life-threatening hemorrhagic cystitis.
And what about the intravesical therapies like BCG?
BCG simply does not penetrate deeply enough into the bladder wall to reliably cure a tumor that has already invaded the muscularis propria. You are just wasting critical time while the tumor gains the opportunity to metastasize distantly.
So the mature, uncompromising board answer is salvage radical cystectomy.
Exactly, and there's a profound philosophical point here that you need to internalize as an oncologist and explain clearly to the patient. Salvage cystectomy is not a failure of the trimodality pathway.
No.
No, it is a necessary built-in safety net.
Wow, that distinction changes the entire tenor of the consultation.
It does. A robust, successful bladder preservation program absolutely depends on close surveillance and the willingness to execute early salvage surgery.
Right. When we initially counsel patients for trimodality therapy, long before the first radiation fraction is delivered, we have to lay the groundwork.
Yeah, we tell them, we're trying to save your native bladder, and the odds are in our favor. But the safety hatch is that if the cancer comes back in an invasive form, we immediately pivot to surgery.
So what's the counseling language you use in clinic when it actually happens?
I see. When we chose bladder preservation 18 months ago, part of our agreement was relentless surveillance and a willingness to change course if the cancer returned in an invasive form. Unfortunately, that is what happened. The radiation and chemotherapy have reached their safe limits for you. The only treatment that gives you the best chance of long-term control and a definitive cure now is the salvage removal of the bladder.
It's a devastating conversation for the patient, but it is the honest, oncologically sound path.
It is.
We establish the oncologic necessity, but we also have to be brutally realistic about the surgical realities. Taking out a bladder that has been heavily irradiated 18 months ago is not the same operation as an upfront cystectomy on virgin tissue.
Not at all.
What is the surgical reality check here?
The reality is that operating in a previously irradiated pelvis is significantly harder, longer, and more perilous for the urologic surgeon.
Because the radiation fundamentally alters the tissue architecture, right?
Exactly. The normal surgical tissue planes become obliterated by dense, woody fibrosis. The blood supply to the pelvic tissues is compromised due to that endarteritis obliterans we discussed earlier.
This translates to a substantially higher risk of perioperative complications.
Yes, higher risk of severe bleeding during the dissection. There is a much higher risk of poor wound healing and anastomotic leaks when the surgeon tries to connect the ureters to the newly created ileal conduit.
Because the segment of bowel they are using may have been exposed to scatter radiation dose during the initial trimodality therapy.
Exactly.
So the clean, balanced counseling sentence you want to deliver to the patient and the board examiner is this: salvage cystectomy is oncologically necessary and represents your best chance for a cure, but it is surgically more difficult and carries higher morbidity than an upfront surgery would have.
Yep. You demonstrate that you understand the definitive oncologic need while fully respecting the surgical difficulty your urology colleagues are going to face.
That balance is what separates a novice from an expert.
Truly.
Well, we've covered a massive amount of high-yield, complex ground today. We've tackled the post-cystectomy radiation paradigm shift, the intricate biology of extranodal extension, the historical trials, modern IMRT target volumes, the surveillance protocols for field disease, and the salvage pathways for trimodality failures.
Let's synthesize this into actionable takeaways.
Let's run through the core clinical pearls. Pearl 1 postoperative radiation is a highly selective strategy. It is reserved for very high local regional risk patients, those with PT3B or PT4 disease, positive pelvic nodes, especially with extranodal extension, or positive soft tissue margins.
Got it. Pearl 2?
Pearl 2. The modern target volume is the cystectomy bed plus the local pelvic nodal basins. Do not rely on the old margin-based Baumann consensus. You must spot weld the bed, the internal and external iliacs, the obturator, and crucially, the presacral nodes.
Right. And Pearl 3? Pearl 3. The BART trial is your modern evidence anchor. It proved that using modern image-guided IMRT to deliver 50.4 GY improves pelvic control with acceptable toxicity.
And the final pearl.
Pearl 4. Always apply the 3-bucket rule for post-trimodality recurrences. Superficial recurrences can receive local conservative management. Muscle-invasive recurrences mandate salvage cystectomy. Distant recurrences require systemic therapy.
Perfect. Now it is time for the board blitz. I'm going to act as the proxy for the listener. I want you to hit me with 3 rapid-fire board-style questions based on everything we just discussed. Let's see if we can apply the logic under pressure.
Let's do it. Question 1. You are evaluating a 68-year-old man in the multidisciplinary clinic. He is status post-neoadjuvant cisplatin-based chemotherapy, followed by a radical prostatectomy and extended node dissection. His final pathology demonstrates YPT3B disease, PN1 with extranodal extension. His surgical margins are negative. He's recovering beautifully. What is the best next step in his management?
Okay, I am scanning the risk factors. He is IPT3B, he has positive nodes, and he has extranodal extension, all present despite aggressive neoadjuvant chemotherapy. This is the textbook definition of very high local regional risk.
Yep.
So the best next step is a multidisciplinary discussion. I need to involve medical oncology to offer adjuvant nivolumab based on the systemic risk, and I need to offer selective postoperative pelvic radiation as a local regional control strategy to prevent a devastating pelvic recurrence.
Outstanding. You didn't just reflexively say radiate him. You contextualize the radiation within comprehensive multidisciplinary care and accurately define the specific goal as local regional control, not overall survival.
Right. Hit me with the next one.
Question 2. You decide to proceed with postoperative radiation for a high-risk patient. You sit down at your planning station and pull up the simulation CT. What is the best target volume based on current board-style teaching?
I am actively ignoring the old Baumann consensus. I am drawing the cystectomy bed plus the local pelvic nodes, and I know those local nodes encompass the internal iliac, external iliac, obturator, presacral, and distal common iliac basins.
Nice.
I am going to mandate daily cone beam CT image guidance to track the bowel and the stoma, and I am going to prescribe 50.4 GY, taking extreme care not to compromise my oncologic target,
Yeah.
just to carve out a massive bowel avoidance structure while still respecting normal tissue constraints as best as physically possible with VMAT.
Flawless execution. You spot welded the exact anatomical brackets where the microscopic disease wants to fail. Last question, question 3. A fit 70-year-old man is 2 years post-trimodality therapy. He had a complete initial response. On his routine surveillance cystoscopy, a new localized muscle-invasive recurrence is identified and biopsied. There is no distant disease on his restaging CT scans. What is your best recommendation?
He falls perfectly into bucket 2 of the 3-bucket rule. He has a localized muscle-invasive recurrence after prior full-dose definitive chemoradiation. I am absolutely not offering more external beam radiation, and I am not offering intravesical BCG.
Good.
My singular recommendation is salvage radical cystectomy with a pelvic lymphadenectomy and the creation of a urinary diversion. I will counsel him that it is surgically difficult, but it is his only remaining curative option.
Excellent.
Yeah.
You avoided the dangerous trap of reirradiation and correctly recognized the vital safety net of the bladder preservation pathway.
As we wrap up this session, I want to leave the listener with a final provocative thought that builds on what we've discussed today. We spend so much intellectual and emotional energy struggling to balance the late toxicity of postoperative pelvic radiation against the desperate need for locoregional control.
We do.
Right now, we use pathological staging like PT3B or extranodal extension as blunt statistical instruments to guess who actually has microscopic disease left behind in the pelvis.
It truly is a statistical guess. We are radiating 100 high-risk patients to benefit the 30 or 40 who would have actually recurred in the pelvis, while subjecting the other 60 to the bowel toxicity of the treatment.
But the next frontier, the technology that is going to completely revolutionize this conversation and render our current pathological guessing games obsolete, is circulating tumor DNA or ctDNA.
Absolutely.
Imagine a world in the very near future where, instead of guessing based on a piece of tissue under a microscope, we simply draw the patient's blood 3 or 4 weeks after their cystectomy. We use next-generation sequencing to look for molecular residual disease in their plasma.
It's incredible.
If the patient is ctDNA positive, we know definitively that the cancer is still present in their body. For those patients, we aggressively target them with our most potent combination of pelvic radiation and systemic immunotherapy. But if they are ctDNA negative, meaning there is no detectable molecular trace of the cancer, we can confidently spare them the bowel toxicity of pelvic radiation entirely. It will shift our paradigm from clinical guessing to true molecular precision targeting.
That is the inevitable future of oncology. We are moving away from population-based risk stratification toward highly individualized, molecularly defined risk. The trials investigating ctDNA-guided adjuvant therapy are accruing right now, and it is going to be fascinating to watch that data mature over the next 5 to 10 years. It will change everything we just talked about.
It truly will, but until those trials report out, we have to master the tools we have today. So let's do a final summary of our core mission. The golden rule you must walk away with is this. Radiation does have a vital, highly selective role after cystectomy in high-risk patients to prevent catastrophic pelvic failure. And similarly, salvage surgery does have an absolute non-negotiable role after definitive radiation when a patient presents with a muscle-invasive recurrence. You need both modalities applied at the exact right moment to manage this complex disease.
The dynamic interplay. If you understand that, you will provide exceptional care.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Thanks for tuning in.